Huh. Yeah, I'm in Hollowell, and that's about what we got.
Hey, Kevin, I'm just sort of in the background here.
Okie dokie, Tom.
Hey, Deb. Hey, how you doing, Kurt?
I'm good. I miss meeting with all of you.
I know, same here.
I know this will probably sound weird, but I enjoyed the work that we did, and I want to get back to it.
On
Yes,
Mid-Coast, solid
absolutely.
waste, yeah. Yeah. Well, there's certainly more to do.
Yes, there's always something to do.
Here we are.
Hey, Mike.
Hey, Kurt, how we doing?
I'm good, my friend. How are you?
I'm doing well, doing well. Deborah, hi.
Hi,
Doing well,
Mike, how are
thanks. How about
you?
yourself? So,
Good.
are we going to be treated to your dog tonight?
Oh, you know, I
Oh,
hope
no, I don't
not.
mind.
They're in the other room. They're in the other room with the doors closed. So
Yeah, yeah, they may visit.
it's funny how during all this pandemic stuff, we had so many dogs and so many, it used to be, because I've telecommuted basically, for a decade or more. And it used to be, oh my God, I can't have a dog or any kind of, personal stuff happen. And I think we've all grown so used to it
Yeah,
that everybody has dogs and personal
it's
stuff.
what. Yeah, yeah, it's what we do now, right? Yeah.
Yeah, yeah. Yeah.
Indeed, yes.
Well, at least we've gotten a little snow, but
Not as much as I thought we were going to
still,
get. I mean,
um,
but
still fairly snowless
yeah,
winter like
yeah,
last year, right?
and yeah, I wonder if it's going to make any difference with the come spring with the tick population. I don't know if it's been cold,
Yeah.
because they really don't have as much insulation. I don't know how much they need.
Yeah, that's a good point. Yeah. Well, it's going to make a difference with our salt budgets, right?
I would think, yeah.
Whoops. Denise is, hang on here. One of the board members forgot the 5:30 thing, so I'm trying to make sure I got everybody doing what they're supposed to do here.
Yeah, well, there are a lot of Zoom invites floating around.
Yeah.
We've got 3 tonight, 2 tomorrow. Yeah. Okay.
Okay.
All right.
Oh.
Hey, Sarah.
Hello, how are you?
Good. How you doing?
Busy.
Oh, I know.
Let's see, who else is here? Just us? Nope, there's,
No, we got Ray and Kern, and I haven't. I gotta.
very,
I'm not
I'm
seeing
not-
everybody else.
yeah, I'm not used to doing these meetings on the iPad. So there's a lot of folks here. Okay, Amy's here. Hi, Amy.
Maybe I can see more people if I do that. Well, I can, yeah.
There we go. There's my tiles.
Yeah, I just found mine too.
Brian Powers is having one of those days on the job site. So he said if he gets back to the house before this is over, he will try to log on, but he couldn't promise anything.
They have more than one member that's gonna participate? Do you know?
Who?
Hope, 'cause that's where Brian Powers is from.
Me.
Oh, I'm
Sarah.
sorry, Sarah.
Yeah.
Oh, good.
I'm here too. I was just,
And Amy's here also. Yeah, thanks, Amy.
yep, I was just fighting with a log trying to get it in the wood stove. So, normal stuff.
Yep.
Hi, Lily. Lately, nice to see you.
It says on you, Deborah.
Sorry.
Does it say Deborah Hall under my picture?
It does.
Oh, it does. Oh, sorry, guys. You know what happened is that's because I sent. That's Denise, but I sent around my my calendar.
Oh, so
Everybody just to remind them. So you must have clicked on
I could
that,
not put it
obviously.
together.
So now
Yeah,
you,
thank you, but
well, we have Denise Munger instead of Deborah Hall, underneath Deborah Hall, or wherever she shows up on yours.
Hey, Dave, is this going to be recorded?
It is being recorded currently, so be careful what you say.
Okay, now what I was
And,
thinking is,
we can certainly share it with you. It'll be up on, it's currently live on the town's YouTube channel, and will be video archived there as well.
okay, I was thinking, because I don't see, I'm not sure that I see that Sam got the email, and I would like her to see this, and it's a little late notice to ask her to jump in. So I'll ask her to maybe view it at her leisure on the recording.
Okay, my apologies. I thought I'd included her in the email list, but I may have not. Sorry about that.
Yeah, it's all right. I was just looking at the participants and the invitees. And so she may very well be on the email list, and I'm just not seeing it in the place that I'm looking within the meeting.
Dave, are we all set to start? I guess I'm gonna kick this off to introduce Kevin. So if you tell me we're good to go.
We have 17 panelists and a few people watching on as attendees. I would say go at this point. Nobody said they weren't coming, but
Okay, great.
Have at it.
Thanks. Thanks, David. So for those of you that don't know who I am, Bill Post, I'm the town manager for the town of Rockport. I was the one that chosen to introduce the topics tonight. So I appreciate everybody that's in attendance. I don't think we'll go through introductions just because it's so difficult on Zoom to do that. But I'm here to introduce Kevin McGinnis, who is our lead consultant on this EMS evaluation project. And for those of you that don't know Kevin, he He's been an EMS system builder and active emergency medical care provider since 1974. He has undergraduate and graduate degrees in healthcare and hospital administration. He's been a paramedic chief for several different types of ambulance services, including volunteer, private, and hospital-based ambulance services. And he's been a hospital emergency department director as well. He served as Maine's state EMS director, trauma manager, and community paramedicine coordinator a period of more than 20 years. And in 2001, he coined the terms community paramedic and community paramedicine. And today, over 200 communities utilize some form of community paramedicine. He authored the National Rural Health Association book, The Rural and Frontier EMS Agenda for the Future, and its follow-up, the Rural and Frontier EMS Tactical Plan 2020 to 2023. He also created the nationally recognized Informed Community Self-Determination process for evaluating emergency medical services, and has evaluated ambulance services throughout the state of Maine, which is one of the reasons that the town of Camden, the town of Rockport, and Penn Bay Medical Center participated in funding this evaluation so that it would benefit all 4 of the communities in our region, plus Penn Bay Medical Center. So with that, I think I'll turn it over to Kevin, and he can introduce, well, he can take off from here. Kevin?
Thanks a lot, Bill. Can you hear me okay?
Yes.
Great. Well, thank you all for taking the time to share in this update with us. We're squishing a whole bunch of material into a relatively short period of time. If you received a packet that contains slides that I'm going to be using, they have a lot more slides that I'm presenting, mostly involving sort of an EMS 101 explanation. I'll do a little bit of that, but not too much. This project came from, originated, was when Northeast Mobile Health Services took over the 911 response contracts for Camden, Rockport, Hope, and Lincolnville in 2013. Northeast had done interfacility transfer service for Penn Bay Medical Center prior to that. Northeast is a private family-owned service housed in Scarborough. Some of the issues that kind of resulted in this project were that transition from what was at the time Camden First Aid, a smaller community-based service with its hometown characteristics, and in came a larger private service with access to more resources and some economies of scale and whatnot, but felt by some perhaps to be not as hometown, understandably. There are a constant set of tensions that exist in EMS where it's offered, and it's no different here. In this case, we have Penn Bay Medical Center, which depends on the service and its crews and vehicles to take patients from Penn Bay to larger hospitals, and often on an emergency basis. And then we have 911 demanding responsive ambulances very quickly. We have had over the past several years reports of tension and some disconnects between Northeast and colleagues that work in public safety and fire response, to a lesser degree police, town government, and then some of the stakeholders in the communities that depend on having a good, present, fast ambulance service. There's clearly been a desire on the part of fire service to have more to do with EMS capability or provision. There have been some proposals floated in the past year or so for a fire service-based ambulance service. So we know that exists. And frankly, there have been anecdotes and reports of people concerns about the timeliness of response, perhaps the overuse of Rockland Fire Department for mutual aid. There have been reports here and there about issues with some staff on Northeast, their performance, their patient interaction skills and attitudes, and then Northeast visibility, community events and services have all sort of contributed to why we're talking today. But right at the core of it is we need to make a decision in our towns here about what is the right EMS for the area and for Penn Bay Medical Center. And so Camden, Rockport, and Penn Bay funded this project, knowing that we have a contract year beginning next July, where we need to make some decisions about how that's going to shape up. And at the same time, we have this hugely complicating factor that gets into planning for things like this and trying to start up a new operation amidst the COVID-19 environment, and the financial complications it's going to present for towns and for public safety are just a mix that makes it difficult. Before I get into all that, let me just talk a little bit, put everybody on the same page about EMS terminology really briefly. EMS professionals, EMTs and paramedics, have the usual ambulance response for 911 calls that you can picture because of exposure to the media. We also, however, in some circumstances, provide emergency medical care until the ambulance arrives. If we're particularly in more rural areas, we may have a small fire department that will send a brush truck out with people with medical training to do some care before the ambulance gets there. We have ambulances that do interfacility transport, taking patients from a smaller hospital to a larger hospital for more advanced care. And then there are a number of things like the community paramedicine that was mentioned that are non-emergency care, primarily aimed at keeping people from needing to call the ambulance. And EMS is more and more doing that in their communities. The license levels that we have in Maine are basically 4, and they're consistent with what you find around the country for the most part. The very basic levels are emergency medical responder, somewhere in the neighborhood of 60 hours or so of training, 40 to 60 hours of training, prepare someone to provide medical care before the ambulance gets there. It's very basic. Emergency medical technician or EMT got about 150 hours worth of training, provides, again, basic life support. It's the entry level for an ambulance, for attending a patient on an ambulance. And I'll get into what they do in a moment. The advanced EMT level is about double that. It starts providing patients with more advanced airway interventions, some drugs, and some other types of care. And then at the top of the heap at this point is paramedic, which can be as much as a couple thousand hours or more training, also involving an associate's degree in most cases. I would just make a note that of all the 911 calls that come in, somewhere in the neighborhood of 40% of them approximately will require ALS of some sort, advanced life support of some sort, with an advanced EMT or paramedic. The rest can be handled with basic life support. This is just to give you a sort of take a look at the colors, and starting from the left with EMR or EMT, the skills that they provide are very basic. A few drugs, splinting, bleeding control, oxygen, automatic defibrillation, some things like that. Moving to advanced EMT, a few more skills, some of the airway interventions, and the paramedic on the right side, 2 columns worth. I won't say any more, except that most of those are some 24 drugs that are able to be brought to bear for certain conditions that are life-threatening. I'd also mentioned that EMS comes in many different flavors in terms of the types of agencies that operate the EMS response agency, or sponsors that operate those. There are 276 licensed EMS agencies in the state. Most of those are fire service, either first responder units, non-transporting, they get there before the ambulance gets there, or ambulance services. Rockland Fire is an example of that. There are a large number of nonprofit and independent community EMS services, such as St. George. There are independent municipal services, private EMS services like Northeast Mobile Health Services, hospital, college, and tribal services as well. So a big flavor variation. Why this project? Well, this project follows on many months up to years of discussion among public safety agencies about which way EMS should go. And, is Northeast doing the job? Could fire do a job as well or better? Are there other models? Could the hospital offer an EMS service that would be different or better? And as I mentioned, there have been proposals, specific proposals floated at public meetings about fire-based proposals. Tom Judge, who is with us today, who's the director of Life Flight and is a resident of St. George, has been a volunteer facilitator in those discussions and kind of helped lead that discussion to this project that was ultimately funded by Camden, Rockport, and Penn Bay. Tom continues as a volunteer facilitator in this project. I'm helped by a couple of colleagues, a fellow who's the director of EMS in Franklin County in Western Maine, and a colleague in California who specializes in EMS planning and contracts development and administration. The steering group that has guided this project are before you there, representatives from the towns and from the hospital. And they've all been very helpful in making a bunch of decisions about where this project has gone from and to. For the last 2 to 3 months, we've been holding steering group meetings, generally as often as once a week. Hope in Lincolnville has sent representatives as well to participate. So we have all 4 towns and the hospital providing input. The evaluation itself was a thorough evaluation of Northeast Mobile Health Services, from inspecting all of its vehicles and practices and policies and procedures and records and whatnot, interviewing a lot of its staff and leadership. We also did interviews with many of you and over 40 stakeholders in the 4 towns and the hospital, as recommended by the steering group, or those that we wanted as staff to particularly interview for ourselves. We also looked at performance data from Northeast and got that from Maine EMS, from Knox County Dispatch, from Northeast itself, to look at its performance as well as those of some comparison agencies in Rockland, Belfast, Damerscott, Norway, and other places. So we could get an idea of what the practices are in similar areas for similar ambulance services. We also asked Maine EMS and the regional EMS process for quality improvement oversight about their history of Northeast's complaints, incidents that may have come up, any licensing actions that have been taken, and that sort of thing. We also went and asked Northeast specifically, as well as fire service leaders in the 4 towns, for their thoughts on other operational proposals coming from like the ones that have been floated publicly by the fire service. And finally, we looked at some other models around the state and country, in particular, some mixed fire service and private models, like one finds in Brewer, one finds just starting now in Waterville, as well as the ambulance tax district model, which exists in a couple of places in the state. The process of the steering group coming to findings involved a couple of decisions about directions that we took, and then revolved mostly around developing a set of options that we might consider, and then whittle down into options to be considered by decision makers, either at town meeting or at select board meetings or in the hospital. And so we ended up with basically 10 options that we looked seriously at, considered the pros and cons of those, the costs, and especially the likelihood for success in the current time frame, with July sort of looming out there and the COVID environment with all of its complications. I'm just going to touch now on some of the findings from the data review, interviews, and consideration of those options, and how we selected the options. This is kind of an eye chart, and I apologize for that. Don't pay attention to the details. You can look at them in your handouts if you have them. But there are the contracts that Northeast now has with the towns and with Penn Bay Medical Center have some provisions, requirements for a couple of things. This one is that there's a provision that requires a paramedic level licensee to respond on 95% or more of calls that come in as advanced life support requiring calls. And I would just say, this is the kind of report that has been provided to the towns on at least a quarterly, if not monthly basis. Long story short, they've met that requirement for the last couple of years. As far as I know, they've always met that requirement. There have been no penalties assessed against that. Likewise, in terms of average response times by towns, the standards for those vary, and they've actually changed a little bit over the last couple of years, but as of 2019 to 2020, they varied from 9 minutes to 17 and 19 minutes, depending on where you were. And just again, one more time, those requirements were met in all cases by Northeast. We looked separately, our evaluation team looked a little separately at some other data from Maine EMS, just to get a sense of whether the response that Northeast has is reasonable for the type of community served and for the geography and type of service that it is. And just sort of showing the two types of response into the more urban centers as opposed to out in the more rural areas. If you look at the top row, which is Northeast response to Camden, with an average response time from this data of 9 minutes about, and then to Rockport, which is down the fourth line, which is a little under that, 8 minutes, or 8.8 minutes. And compare that with Rockland Fire responding into Rockland. Now, Rockland's got a much smaller response area even than the urban areas that Northeast serves. And so you have a shorter response time of 7 minutes. And then if you look at Belfast responding into Belfast, that's 11 minutes. So that spread is pretty comparable among those four more urbanized centers for response, and Northeast is not unreasonable in that response. We looked at more rural areas. To Hope, Lincolnville, we're looking at 16 minutes, 19 minutes, consistent with the data that we looked at up above. And you compare that with Belfast down at the bottom two rows, Belfast going to Northport or Belfast going to Morrill, 17 and 18 minutes. It's all in the same ballpark. The only reason I have the last column is there is a discussion about how we measure response time and what the appropriate way to measure it is. Using an average is okay, but unfortunately, when you try to look for outliers, look for those calls that are exceptionally long or exceptionally short, for that matter, with an average, it's hard to find them. If you do 90, what's called a fractile, in this case, a 90th percentile, just simply means at the top line that Northeast responds to Camden 90% of the time in 14 minutes or less. That's what that figure means. And all the rest of them are consistent with that. And what that does is it identifies a group of calls in the 90th and above that need to be looked at, perhaps. And you can do 95th or 75th, depending on how many you want to review regularly. From our interview experience, we found a number of things that kind of reflected some of the issues that led to this project, and some which have some apparent causes. We know that in terms of dispatching Northeast and the communications that go on with dispatching for 911 calls or dispatching Northeast to the hospital for an interfacility transport, there's some issues with MedCom, which is Northeast Dispatch Center located in Bangor. They have to interact with both MedCom and Knox County Dispatch, and also an app that is used by the public safety responders in the towns to be aware of what vehicles and what crews are available at any given time. This doesn't always go smoothly, and is something that needs to happen because it does lead to some frustration. It also leads to some discussion about what is the right response time measurement to use when you're trying to determine what's reasonable and what's not. When Northeast first started out, there were regular, close, routine communications between Northeast and hospital staff in the emergency department to do planning for interfacility transports and meet with them, if not certainly weekly or even more frequently than that, to help. There were more communications between Northeast and fire service folks, and perhaps even with other town officials. And that has sort of degraded over some time. There has been, we had I'm sorry about that, number of anecdotes of people that worked with Northeast staff, either coming into the hospital or on the scene, or people that had seen crews operating, wondering about the professionalism of some of the Northeast staff. Now, mind you, a lot of these folks are coming in from other areas because Northeast is a large service, as opposed to always seeing the same community-based faces coming out of the ambulance. So we don't know to what degree that adds to that sense, but it's there. And so we have seen some of those reports coming out of the interviews that we got. In particular, folks saying, well, geez, the Rockland Fire Department EMS folks are always very professional and always very appropriate and whatnot. And sometimes Northeast is inconsistent in that regard. On the other hand, in the interviewing that we did, we by and large had positive feedback on Northeast and its responsiveness, its timeliness, and the way its staff interacted professionally on scenes. And that was from both fire staff, some cases the hospital staff, police, and others in the community, sort of community leaders. We did find that mutual aid was incurred almost once a week in 2019, and there were some heavier periods in 2019 than others, and less so in 2020. Rockland Fire indicates that has become much less of a problem than it was at one point, not being used as much. And there's, just to add, there's an $800 penalty every time that Northeast uses Rockland for that. They have to pay Rockland $800, and Rockland gets to bill the call. So there's no incentive for them to use that. Staffing shortages were reported by all hands on deck and blamed on the mutual aid use in September and other times in 2019. But one of the big issues that was sort of universally reported was a lack of supervisor presence and oversight for up to 3 years or so at the Rockland base of Northeast, that led to some of this inconsistent behavior on the part of staff or attitudes or perhaps even clinical practices, not having, lacking that kind of supervisor oversight. And that obviously would have contributed to some of the reduced communications or communication problems among everybody who had a stake in this. When we looked at the data, again, as I just sort of hinted at with the data I showed you, we didn't see any real time response reliability problems, but there's definitely a need to get on the same page as to what we're going to use to measure what is acceptable, and that the contracting process with Northeast, if it's going to be continued, definitely needs to have that worked on in terms of measures for accountability that are used, and the expectations that people have about how often they're going to meet with Northeast, who's going to meet, and what they're going to do about chasing down problems or calls that have taken too long, that sort of thing. There's clearly, though the time response seems to be reasonable for Northeast, there's value here for developing a first responder capability in the four towns, obviously particularly in Hope and Lincolnville. And this has been something of discussion in the area since Northeast came in 2013. There was a first responder, a less formal first responder capability in the towns under Camden First Aid. They just had those people be members of Camden First Aid. So there was some first responder capability that has evaporated to a degree. And they've just been not a successful effort to date to develop that first responder capability. There have been no issues with Maine EMS or of a licensing nature or complaints that have not gone unresolved or that are under review. There have been no reports at all through the region or Maine EMS licensing process. And there have been no penalties assessed by the towns for any contract problems. So we get down to the options that have been developed by the steering group. And I put these into basically 6 buckets. And I'll try and get through them as quick as I can here. Option 1 was basically status quo. The cost of doing that, right now, the contract cost to the towns are around $300,000. Would be about 311 or so, including a consumer price index based increase that Northeast would tend to seek. The steering group rejected that status quo option as not responsive to the issues that I've just described. If you just tell them to go on doing what they're doing today, it's not going to solve anything. There's a 2.0 option. I'll get to that in a little bit. And then go on to the 3.1 to 3.3. And this reflects around the comments that we heard from the interviews that said there have been staffing problems. Perhaps they don't pay enough or can't afford to pay enough under the contract. Or maybe they need to put on a new truck to address some of the options or some of the problems that we saw with the use of mutual aid and whatnot. Well, the finding of the steering group was that the data really don't support either shelling out money to Northeast to pay their crews and be competitive with Bangor and Portland and other places that we would seek workforce. There are workforce issues throughout the state in EMS, throughout the nation in EMS. And they're very complicated. I can't talk about them right now, where they come from, but just suffice to say, there aren't enough paramedics and EMTs out there. Putting on an additional truck at that expense and talking somewhere between $750,000 and $1.5 million to accomplish one of these options or both, to pay more and put a new truck on, just simply are not supported by the data for response time and response capability. It's our experience around the country and in Maine that the resources that are there right now ought to suffice for the job that needs to be done. If we go to the next option bucket, which is basically saying, okay, instead of going to Northeast, let's develop a fire-based 911 response and interfacility transport capability. That would be somewhere over $1 million to start up in terms of buying ambulances and some other things, and over $1 million a year to operate. Could be somewhat less in cost if it was operated out of Rockland using existing resources and leadership from that source, putting an ambulance in the West Rockport station and the Camden station. So it would come in a little bit less than that. This finding for this is going to be what I'm going to say for the next 2 buckets. And that is this. The evaluation at this point doesn't support the need for such a huge expense now. Because creating a new EMS service right now is essentially like changing a horse in the middle of a madly running river. Given the time frame that we have to operate July 1 and the current COVID uncertain environment in terms of how much financing is going to be available coming out the other side of COVID. And the whole business of starting up an ambulance service in the middle of the COVID response is just unreasonable. It's something that would probably be even irresponsible. I go to the fifth bucket, which would be starting a fire-based 911 response for EMS, but keeping Northeast as an interfacility transfer resource for Penn Bay. This would be somewhat less, it'd be $600,000 or thereabouts to start up, and just under $1 million of annual operating costs. Again, the same recommendation, and I missed a piece of that in the last one. I'll say it here. The evaluation doesn't support this level of expense, and trying to start a new type of ambulance service under this setting and environment would not be well advised. Also, we are going to, what we would recommend is tabling the ideas that would be included in this option for further consideration over the next year or so. The last bucket is one that we don't have a cost for, but it's basically looking at all the other options that we see as being possible for this area. They may be those mixed fire and private models that I mentioned that are being done in Brewer with Northern Light Health and Brewer Fire, or in Waterville with Waterville Fire and Delta Ambulance, or in one of the tax districts that have been formed for ambulance in the state, or a hospital-based service. I think all of those options should also be considered for further possibility. The option that we did look at the hardest and ended up recommending is essentially continuing Northeast as a primary provider, but starting to develop a fire-based first response capability, and also working service improvements into the current contracting process, completely rewriting the contract with a number of accountability clauses, performance measures, supervisory staffing requirements, and dispatch communication fixes, which should not cost any additional funding. It's a matter of getting everybody on the same page. And therefore, offering a new contract to Northeast for 1 year with a second year option. And the cost of that would be somewhere in the neighborhood of $403,000, which would be $100,000 more than is being spent now. Starting the first responder capability would involve all 4 towns for a relatively small investment. The fire chiefs that have participated in discussions, all 4 have concurred with the general direction of this. It would be essentially licensed by one fire department. Management might be shared, but it would at least be licensed by one, and call pay for those that respond would be administered by each town in which the calls occur. And finally, the steering group recommended initiating a further planning initiative to consider regionalization of EMS in this area. Not all of Knox County necessarily, but certainly looking at Rockland, Rockport, Camden, Hope, Lincolnville, and also maybe some of the others, Thomas and Warren, Union, that might be interested. And this is not only for EMS regionalization, but consideration of fire service regionalization is two down the road. And therefore, we feel that if that is done, that there should be some subject matter expertise in fire service EMS initiation in that process. And this regionalization planning should also include consideration of all those 3 buckets of options that I mentioned before. Just to get into the cost breakdown of that $403,000, again, a basic contract with Northeast somewhere in the ballpark of $315,000. In terms of the regionalization planning with a municipal planning facilitator, we have gone out and gotten an estimate of $17,000. So we said 20,000 here. And then initiating a fire-based 4-town first responder service. We'd expect it would start July 1 with planning and recruitment and training as need be, licensing, getting everybody ready to go, coordinated with dispatching, coordinated with Northeast, and that sort of thing for a January 1 startup. And there would be call pay for those. We're figuring there'd be about 15 responders to go to the more severe advanced life support requiring calls, as well as calls that just need extra hands. And currently the fire departments respond to lift assists, other things that they just need, Northeast needs some extra hands to bring the patient from wherever they are to the vehicle safely. And that would continue. There would be initial expense for larger equipment supplies for those 15 people and for the service. Northeast is pledged to provide replacement soft supplies like bandaging materials and that sort of thing on a one-for-one basis. And that would be around $30,000. And then there'd be some administrative costs and insurance. We expect that in year 2, the overall cost would be about the same, obviously minus a larger regionalization plan cost that will go away. And as far as the first responders are concerned, you're going to trade a full year of call pay for having bought a bunch of equipment. So the cost of that will be about the same. With that, I'd like to take any questions that folks might have and invite anybody on the steering group to add their 2 cents worth. We're going to need to do an unmute. Hi, Sarah.
Just wanted to say thank you again to Camden and Rockport for extending the invitation to the little towns to join in on this. It's a good overview of what we've talked about, and I think we've got a fairly good plan for moving forward.
Bill.
Hi, Kevin. Yeah, thank you. I just wanted to make it clear to everyone that when we're looking at the contract with Northeast Mobile Health and the potential first responder expenses, those are for all 4 towns. So those aren't broken up by individual towns. So obviously there's less of an expense for the Northeast contract, for the Hope and Lincolnville, and different expenses for Rockport and Camden. And the same thing can be expected for the first responder program, although it's obviously we're planning this, so it's really, as Kevin has described, there are certain estimates that we're putting in there, assumptions going into this, especially around the call pay. So a lot of that remains to be seen. But I will say from Rockport's perspective, when we go into our budget review sessions, which I think starts probably next week, I am building in some funding from Rockport's perspective, a share, if you will, of that first responder program, so that we can have that debate with the budget committee and the select board. But I just wanted to make sure everybody is well aware that those costs would be broken apart with all 4 towns.
Thanks, Bill. Yeah, I'm sorry that I didn't mention that. The proportion for each town of that 400,000, if it comes to that, would be, I assume, broken down the way that the total 300,000 is being apportioned now, but that's subject to debate.
I have a question on that very topic.
Please.
Was there in any of this review or the proposal a review of how the costs are shared amongst the communities and looking at doing that in a different way or alternatives?
Not as yet, no. There wasn't there have been so many ways that communities have shared services. The safest thing to do was to make an assumption, which may be a bad assumption, that that it would be broken up the way the current contract is broken up, which I believe is population based.
I'd be curious to see what different options might be available or a possibility, just because of the way that the cost sharing has gone down thus far, looking at how much, say, Lincolnville and Hope are paying per call relative to, say, Camden and Rockport.
Well, I mean, that's a good point, and I can certainly take that up with the steering group. They certainly, the town officials that are on the group are certainly more familiar with how those kinds of sharing relationships have gone in the past. But, looking at what the call volume has been, maybe maybe a different way than population-based to do that. Other questions, comments? Sarah.
It occurs to me that at one point we talked about getting some language about that would improve the quality of service in the contract for this coming year with Northeast. And it just occurred to me that I don't remember hearing anything about that recently. Where do things stand with that? Because I know that certainly it's hard for those of us on the board in Hope to know how to negotiate an ambulance contract.
Sure. That's a great point, and that's why I have Rick Narad from my friend in California helping me out, who has written ambulance contracts all his life, and is definitely more up on this. He's brought us a number of options to consider for our contracting that include different ways of looking at response time, different ways of looking at penalties for violating response time and other issues. And we've had some discussions already with Northeast about what they feel will cost them money and therefore cost us money if we're going to enforce them in the contract. By and large, most of the things that we've talked about, including different ways of looking at response time management, some requirements for quality reporting, for assuring that there be a supervisor at the Rockport base at all times, those types of things they haven't balked at, and haven't said we're gonna cost you a lot to do those. They said, yeah, those are reasonable things.
Yeah, especially since budget season is upon us. And
Right.
so we're going to need to, and July 1st with the new contract is going to be here before we know it. So we need to get some numbers out of Northeast now, basically.
Absolutely. No, completely understood. And there's the three pockets of numbers that we need: the Northeast, the EMS regionalization plan, and the first responder service plan. I think the last two were pretty much the ballpark we're talking about. It's going to be one of those things where you've got a fixed budget and that's what you got to operate within. The contract with Northeast is the same way, but having more moving parts in it. That's what I've been focusing on every other day or so with those folks. So we're getting there, and I'm looking to have an understanding with them in the next week or two at the most.
Thank you.
certainly. Other comments? Questions?
Kevin, this is Deborah Hall. Thanks for your work with the steering group. I think that you guys have done an awesome job, and I appreciate it very much.
Thanks, Deborah. It's good to talk with you again.
You too.
Well, if that's where we're at, I guess, David, you can cut us off and you guys get to go to other meetings.
Okay, thank you all for joining.
Thanks, everybody. I really appreciate the time to talk with you.
Okay. Thanks, and thank you, David.